Welcome to the deep dive. Today, we're getting into some essential clinical sources. The topic, that really common, sometimes scary thing, the red eye.
Yeah, it's everywhere.
Our mission here is to pull out the absolute must-know guidelines for diagnosis, for management, helping you figure out, is this just irritation or is it a real emergency?
And that's the whole challenge, isn't it? Red eye is probably one of the top reasons people show up to primary care. I mean, the sources say infectious conjunctivitis alone hits like 17 out of every 1,000 people each year.
Wow, that's a lot.
It is, and most of those are, fine, self-limiting. But hiding in there are the real crises, the ones you can't miss. So we're really looking at these two extremes, right? The huge number of harmless cases and the few really high-stakes ones.
Okay, so we need a quick way to sort them, a triage system. Let's focus first on those absolute alarm symptoms, the non-negotiables, and then maybe tackle some surprising advice on treating common stuff like pink eye.
Sounds good.
All right, let's jump into that checklist. What are the definite red flags, the ones that mean serious trouble?
Okay, there are basically 4 key alarms. Get any of these, you need to pay close attention. First one, pain. And I mean real deep ongoing pain, not just like scratchiness or feeling like something's in there.
Okay, actual pain. Got it. What's number 2?
Number 2 is vision change. That covers, well, anything really. Vision getting worse, seeing double, seeing halos around lights or flashes of light, any change like that.
Right. And number 3?
3 is severe photophobia. So light sensitivity that's so bad it actually hurts to keep the eye open.
Okay, pain, vision change, serious light sensitivity. And you said there were 4. The last one feels a bit different.
Yeah, the 4th is nausea and vomiting. If you see that with severe eye pain, it's often a sign of really high pressure inside the eye. Think acute angle closure glaucoma. So yeah, any one of those 4 pops up, that's your signal. It's potentially serious, needs an urgent look.
That definitely helps narrow it down right away.
Yeah.
But the sources also talk about the type of redness being important, not just that it's red, but how.
Absolutely crucial distinction. You've got to differentiate superficial versus deep redness. The first kind, the less worrying one, is conjunctival redness. This is on the surface, in the conjunctiva, that clear layer over the white part.
Okay.
And visually, you can often see this redness sort of move or shift over the white sclera underneath. If you gently move the eyelid, that's your typical look for mild conjunctivitis.
Right, the kind that moves.
Then there's a second type, much more concerning, scleral or ciliary redness. This is deep, doesn't move. And the key sign here is this ciliary or paracorneal redness. It forms a kind of soft purplish red ring right around the cornea.
Around the edge of the colored part.
Exactly, right where the clear cornea meets the white sclera. That border is called the limbus. Seeing that deep, violet-ish color hugging the limbus, especially with pain, that strongly suggests something deeper is inflamed. The cornea, the iris, the ciliary body.
Oh.
That color and location are major visual clues for serious things like keratitis or uveitis.
So just to really hammer this home for everyone listening, superficial redness, the kind that shifts around a bit, usually less serious. Deep violet redness right around the cornea. That's a potential emergency.
That's the key takeaway for visual triage, yeah.
Okay, let's shift gears a bit. Phase 2. Common non-traumatic stuff. Top of the list. Conjunctivitis. Pink eye. And this is where you said things get interesting, because the usual treatment ideas might be wrong.
Well, yeah, it's the classic antibiotic paradox. The sources are pretty clear. For healthy people, both bacterial and viral conjunctivitis usually just get better on their own.
Really?
Both. Yeah. The data shows about 75% of patients, they're symptom-free after a week, and that's whether they got antibiotic eye drops or just a placebo.
Hold on. Let me make sure I heard that right. You're saying the standard guideline is basically don't use local antibiotics for typical pink eye. That feels completely backwards to what most people think.
It does, but that's the recommendation. Local antibiotics are generally not indicated, the main reasons. Preventing antibiotic resistance, which is a huge issue, and also the drops themselves can sometimes irritate the eye even more.
So, just wait it out.
Pretty much. Simple symptom relief, cool compresses, artificial tears maybe, and patience.
Yeah.
That's the standard advice for uncomplicated cases in healthy individuals.
Okay, that's a major point. Avoid the antibiotics for common infections.
Right.
But what about those chronic nagging irritations, like blepharitis? That needs treatment, right?
Right.
But a specific kind.
Yes, blepharitis definitely needs management. It's that inflammation along the edge of the eyelids, often tied to the meibomian glands not working right. Those glands make the oily part of your tears.
Right, crusty eyelids sometimes.
Exactly. And managing it needs this very specific 3-step routine. You have to do it in the right order. First, warmth. Apply warm compresses to the eyelids to melt the gunk, the solidified oils in those glands.
Okay, melt it first.
Second, right after the warmth, gentle massage of the eyelid margins. You're trying to express or push out those melted oils. And third, cleaning or brushing the edges of the lids to get rid of scales, bacteria, any debris.
So it's melt, push, clean.
Melt, push, clean. That's the routine. Consistency is key for keeping it under control.
Okay, we've hit the common stuff, but we need to go back to those rare but really dangerous non-traumatic things. You mentioned keratitis earlier, cornea inflammation. What makes it go from minor to, well, disastrous?
It really comes down to how deep the infection goes. The cornea has layers. The very top layer, the epithelium, usually heals really well if it gets scratched. No big deal. But underneath that is something called the Bowman membrane. Think of it like a protective barrier. If an infection gets through the epithelium and breaches that Bowman membrane, it can get into the main structural part of the cornea, the stroma.
And that's bad.
That's very bad. Once it's in the stroma, the risk of severe infection, ulceration, scarring, and permanent vision loss just skyrockets. Depth is everything.
And you mentioned sometimes the cause leaves a clue, a visual fingerprint.
It can, yeah. There's a specific type called Keratitis dendritica. It's caused by the herpes simplex virus, HSV. If you put a special stain, fluorescein, on the cornea, the pattern of the infection looks like a little tree branch or a fern leaf.
The fern pattern.
Exactly, a dendritic pattern. Seeing that is crucial because it tells you it's viral, specifically HSV, and needs antiviral treatment, definitely not antibiotics. It's a very specific sign.
Fascinating. Okay, and we also need to touch on scleritis and uveitis again. You said they link to bigger systemic issues.
They often do, and that's why they're so important not to miss. Scleritis is inflammation of the whole thickness of the sclera, the white part. It causes this really deep, boring pain, often bad enough to wake people up at night. And the striking thing is, it's often not an infection. The sources say in almost half the cases, scleritis is linked to a systemic autoimmune disease, things like rheumatoid arthritis or lupus SLE.
So the eye problem is actually a sign of something body-wide.
It can be the first sign sometimes. Same goes for uveitis anterior. That's inflammation inside the eye, the iris, and ciliary body. It causes that deep pain and the ciliary redness we talked about. Left untreated, it can lead to serious complications like glaucoma or cataracts pretty quickly.
Right. And that brings us to the absolute time-critical emergency, acute angle closure glaucoma. We mentioned the pain and nausea. How urgent is urgent?
Urgent means hours. This is when the pressure inside the eye shoots up suddenly and dramatically. The fluid can't drain properly. If that pressure isn't brought down like right away, it crushes the optic nerve. You can lose vision completely, permanently, very fast.
Terrifying. Who's most at risk?
Risk factors include being older and being hyperopic, which means farsighted, or having a shorter eye anatomically. That structure makes the drainage angle inside the eye naturally narrower, more prone to closing off, especially if the pupil dilates suddenly, like in dim light or due to stress.
Right, that really paints the picture for non-traumatic issues. Let's pivot now. Phase 3. Trauma. Physical injuries, chemical stuff. Protocols change here, right? Especially with chemical burns.
Oh, yeah. Chemical burns are always treated as severe, especially strong alkalized lye, but also acids, lime, chlorine. And here's the absolute #1 thing, and it feels counterintuitive. You tell the patient, or whoever is with them, to start flushing the eye immediately with water. Copious amounts of water.
Before they even come in.
Yes, for at least 10 minutes solid, at home or wherever they are, before heading to the clinic or hospital. Every second counts. That initial, immediate, prolonged flushing is the single most important step to minimize the damage, the clouding, the scarring, maybe even perforation of the eye.
Flush first, travel second. Got it. Now, what about things hitting the eye? You mentioned high-velocity trauma like metal fragments. That has sounded particularly tricky.
It is. It's maybe one of the most easily missed serious injuries. Think about someone grinding metal or hammering metal on metal. A tiny shard can fly off at high speed, puncture the cornea, go right into the eye. But the patient might only feel like they have something small in their eye, or just notice it's a bit red. Minimal pain sometimes, because it happens so fast.
So the symptoms don't match the severity at all.
Exactly. It's a huge potential mismatch. That's why if there's any history suggesting high-velocity impact, especially metal, it's an automatic, urgent referral to ophthalmology. You have to assume penetration until proven otherwise.
Okay, so that's the scary, silent, high-velocity one. How does that compare to, say, just getting some dust or grit blown in your eye. The low-velocity stuff.
Well, the low-velocity things like dust or a speck under the eyelid, they usually cause immediate, intense, scratchy pain. Feels awful, much worse symptomatically than the potentially perforating injury often does.
So worse pain might actually be less dangerous.
In that specific comparison, often yes. The low-velocity particle usually just lodges on the surface or under the upper eyelid, causing a lot of irritation but not penetration. The high-velocity one might feel like less but do far more damage. It's counterintuitive.
Okay. And what about a simple corneal abrasion? A scratch on the surface. We've probably all had that.
Yeah, a corneal erosion or abrasion. Feels terrible, very painful, light sensitive. But the good news is, if it's just superficial, the cornea heals incredibly well, usually completely better in, say, 1 to 2 days, maybe 3 if it's a really large scratch.
And how do you treat that?
Main thing is pain relief. And usually a single dose of antibiotic ointment is given. Chloramphenicol is common, or afloxacin if they wear contact lenses just as a precaution against infection while it heals.
What about patching the eye? Does that help it heal faster?
That's a common question. The sources say an eye patch can make it feel better, mostly by stopping you from blinking and rubbing it, but it actually doesn't speed up the healing process itself, so it's more for comfort than cure.
Interesting. Okay, one more trauma type. The delayed pain from UV light. Arc eye, snow blindness.
Right. Keratoconjunctivitis photoelectrica, caused by too much UV welding without a mask or lots of time on snow or water without sunglasses. The weird thing here is the delay.
It doesn't hurt right away.
No. The exposure happens, and then maybe half an hour later, maybe up to 6 hours later, then the symptoms hit. Severe pain, burning, feels like sand in the eyes.
Ouch.
It's excruciating. But the key message for the patient is reassurance. As bad as it feels, it almost always resolves completely on its own within about 12 to 24 hours.
Can you do anything for that intense pain in the meantime?
Yes, for really severe short-term pain, you can give local anesthetic eye drops like oxybupropion. But, and this is critical, it's only for very short-term use. The guidelines usually say maximum 12 hours total.
Why the limit?
Because overusing anesthetic drops can actually be toxic to the cornea and delay healing, or worse.
Right.
So very limited supervised use only for that short window of intense pain.
Okay, that covers a lot of ground on trauma. Which brings us nicely to our final phase. Practical takeaways, final advice, especially for contact lens wearers. You mentioned they're higher risk.
They are, yeah. The lens itself is a foreign body, creates a different environment on the eye surface, so the rule has to be strict. Any red eye, any sign of infection, any trauma, stop wearing the lenses immediately.
Makes sense. What else for lens wearers?
Cleaning is key for hard lenses after an issue. For soft lenses, they usually need to be completely replaced before resuming wear after an infection clears. But there's also a really important point about medications, specifically eye drops and soft lenses.
Oh, what's the issue there?
Soft contact lenses are like little sponges. They can absorb things, and many eye drops contain preservatives. Benzalkonium chloride is a really common one.
And the lens soaks it up.
Exactly. It absorbs the preservative from the drop. Then that concentrated preservative sits against the cornea for hours, and it can actually become toxic, damaging the corneal surface.
Oh, okay, so what's the rule then?
The guideline is pretty clear. If you're using eye drops that contain benzalkonium chloride more than, say, 3 times a day, you absolutely must not wear your soft contact lenses during the entire time you're using those drops. Take them out, leave them out until the treatment is finished. It's a direct interaction between the drug and the device material.
That's a really crucial detail. It really underscores how interconnected everything is, the eye, the things we put in it, the things we put on it.
Absolutely.
And, that actually leads perfectly into our final thought for you, the listener, to consider.
Mm-hmm.
We talked about how scleritis, that deep eye inflammation, is linked to systemic diseases like rheumatoid arthritis or lupus in almost half of cases.
Right.
The eye problem is signaling something bigger. So here's the provocation. If serious, seemingly isolated eye inflammation can be the first clue to a complex autoimmune process stirring inside the body, what's seemingly simple, recurring physical issue in your own life? Maybe a skin rash that keeps coming back, a joint that always aches, persistent fatigue you can't explain. Might that be the subtle, maybe ignored, first signal of a complex systemic issue developing elsewhere?
It's a powerful reminder, isn't it? To think holistically, connect the dots, and stay curious about what our bodies might be telling us. Something to definitely mull over. Thank you for joining us for this deep dive.